Right, I'm going to start recording. Today is January 26th, 2023. We have our resident Allison speaking today on hypoxia, and we appreciate your undivided attention. We can get rid of some of these controls. All right, so they can see that there. They can see our faces right now. So, we'll have you go ahead and get started. If you want to do any intro,
Yeah, sure.
And,
Yeah.
a little background.
Hello, everyone. I'm Allison Swets. I'm one of the CA1s in the anesthesiology department. A little about myself. I am originally from New York City and kind of migrated west. After I went to college, I got my first degree in mathematics, and then got married and had kids and decided to go back to school. I went back to Grand Valley and got a nursing degree. I have my RN license, and after my nursing degree, I decided to go to medical school. So here I am, very non-traditional, and I am enjoying the journey. I also have two dogs, German Shepherds, Kuno and Balto, and one is black and one is sable. Black is a kind of a not a usual color, so we really appreciate him. All right, so today we're going to be talking about hypoxia. I want really this to be very interactive. And so I will try and check. Oh, I won't be able to see chat then, right?
You can toggle back and forth if you want, or you can
okay.
Just hit the escape so you can see chat.
Okay. You know what? If you are on, excuse me, if you're on Zoom and you would like to say something, please just unmute yourself. That will be the best way. Okay. So again, very interactive. I'm gonna be asking a lot of questions, and I want you to be thinking also about your stories about patients in the PACU or wherever else you've worked that had hypoxia. Okay, and maybe you can share them with us at the end. All right. So what is hypoxia? What is hypoxia? Somebody tell me. And we'll go faster if people speak up. Because I am a very patient person.
Low oxygen level.
Yay, exactly. Yeah. Everything that I'm talking about today is really not, anything beyond what you already know. Okay, so this is basically a review for everybody. So hypoxia. So there are two words that we use. We use hypoxia and we use hypoxemia, right? And really they're different, but in our context, they're really used the same way. Okay, so when I say hypoxia, I kind of really mean hypoxemia, but what is the difference? Okay, so technically hypoxia with the IA is low oxygen in your tissues, okay? But we use it to mean below normal oxygen levels in our blood, okay? So the technical term for low oxygen in blood, which I just said is hypoxemia. The emia, right, is it stands for the blood. So whenever you see emia in something like bacteremia, it means bacteria in the blood, right? Septicemia, bacteria in the blood. But again, hypoxemia and hypoxia are used interchangeably. Okay. All right. How do we measure hypoxia? Pulse ox. How else? Yes, ABG and VPG. Excellent. Okay. So stats, if they're under 93. Okay. Now I want to mention here that there is research that says if your skin color is dark, like mine, if I have a low SAT of like 89, my real SAT is more like 86. Okay. So I want you to be aware of that if you have a patient who has dark skin and they're already low SAT, be more careful, okay? Because our pulse oximeters, it has been shown that people with darker skin, they measure technically they are lower, but they will measure higher, okay? ABG, the concentration of oxygen in our blood should be over 80. Usually normal is 80 to 100. If it's less than 80, then that is hypoxia. In a VBG, the numbers, I don't understand the numbers as well as in ABG, but if less than 35, then that's hypoxia, okay? All right, how do we see hypoxia in a patient? Just call out.
Dusky color to their
Yes,
skin.
yes, good, what else? Yes. Loopy, confusion, excellent, yeah.
Yes.
What else? Take one more answer, and then we'll go on. Someone with a smoking history, what do you see? You could see club fingers, but when I look at that patient, you know what I mean? Like when I walk around or when you see your patient, and every one of you have had enough patience to say, oh, that doesn't look good. Yes, shortness of breath, right? They're working hard to breathe. All right, so we could see confusion. We could listen to them or see them coughing. We could hear wheezing. They're breathing quickly. They have shortness of breath. They have a low heart rate, and maybe that one took me a little bit like, why would they have a low heart rate? But we'll talk about that. Their skin color could change. It could be red, it could be blue. Again, in darker people, you may not see this, okay? So you have to maybe use other things to kind of help you along. Sweating, okay? All right, so we're gonna go through each one of these symptoms, and I'm gonna try to explain to you why they're having the symptom. You may already know, but if you understand why somebody's having a symptom, you'll remember it more, okay? So why would somebody be confused? Exactly, not getting enough oxygen to the brain. We see this also in people who are flying, like it used to be when you, like in World War I, you went up in a plane, you had oxygen, right? But you could pass out because up there, there's not as much oxygen. It's kind of the same with a person who has hypoxia. It's kind of like they're riding in a plane with no oxygen. So they get loopy, they get confused. Why the cough and the wheezing?
Maybe a comorbidity, emphysema with it, maybe COPD.
Exactly. What is another comorbidity that they could have that they're wheezing? Asthma, okay. And the coughing could be because of the inflammation from whatever comorbidity. Maybe they aspirated, maybe they have asthma, you know. So that could be a reason why they're coughing. Okay. So the lungs reacting to obstruction, right? COPD is an obstructive process, restriction. Asthma is I think asthma is also obstructed, or inflammation, like as in they've aspirated or some kind of pneumonitis. I forget, maybe I'm not saying that right. Okay, why are they breathing quickly? Yes. Yes, like, you know, the brain's saying you're not getting enough oxygen, breathe faster, okay? So the body's recognizing low oxygen, trying to compensate. Why do they have a low heart rate? This is a like extra credit for you if you know this.
Why do they have a low heart rate?
Yes, why do people sometimes have a low heart rate in hypoxia? Yes, exactly. Right. Like I said, everything I'm asking you is not beyond what you already know. Yes, the heart muscle is not getting enough oxygen. So it's like, oh my gosh, I'm getting tired. I have to slow down. Okay. So it can't pump as normal. Why does the skin color change? Yes. Yes. And the vessels that are closest to your skin, right? They are the what? They're the smallest. And so if you don't have, enough blood, like let's say your heart's not pumping, the places that you're not going to get the blood is your capillaries, right? And so if the blood may be still there, the blood's blue, right? You've seen it, if you take out like venous blood versus arterial blood, right? One looks darker than the other. The darkness is kind of like the blue color. Okay, that's what you're seeing. The redness, why would a person's skin color turn red?
Dilation. Vessels opening up.
Yeah, an antihistamine response, a stress response, could also be something else. And I know this is really not, but you might see this in the ED. And I'm thinking of a particular thing. So if you don't get it, I won't be upset. Anybody know? I'll give you a hint. It's some kind of poisoning.
Carbon monoxide.
Carbon monoxide. Okay. All right. So blue skin, the blood doesn't have any oxygen, right? It's closest to the skin. And so that blood is blue. You see a blue, dusky person. Red skin could be a stress response, histamine release, could be poisoning like carbon monoxide. Okay. All right. So now we're going to review just some lung anatomy. Okay. And when you understand the anatomy, you will understand why things go wrong. Okay. So just bear with me. All right. So let me see. Can you see? Oh, yeah. Everybody can see this cursor. Let me put that out. Okay. So we're going to the path of air. Okay. It goes in I don't even look at the terms. Your air goes in what? Your mouth or your nose, right? It goes down your trachea into your lungs, and it ends up at the alveoli. Okay. So yep, okay, perfect. Oh, wait a minute. Okay. So here's a big blow up of the alveoli. And the reason why I show you this is because I really want you to understand what's going on in the alveoli, right? What's going on in the alveoli? And what else exchange? Exchange with what? Yeah, CO2 goes out, oxygen comes in, okay? So it's really important that you are able to exchange. If you cannot exchange, you're not getting oxygen. Okay. All right. And here's just a cartoon version of the alveolus and showing the exchange. Carbon dioxide is going out. Oxygen is going in. You see the red blood cells, they're turning from blue to red. Okay. Once they get oxygen. All right. Okay. So after the alveolus, where does the blood go? Or after the gas exchange passing by the alveolus, where does the blood go? Goes to the heart, right? And so then the heart pumps it out to where it needs to go. All right, perfect. Okay, so you can imagine that if we have problems any place along the way, right? You are going to have hypoxia. If the lungs are not working, if your alveoli are not working, if your heart's not pumping, okay, you're gonna have pathology, okay? And before we get into like the groups of pathology, I want you to think about what causes might be based on the anatomy. So let's start with the lungs. What pathologies might cause you not to be able to get air into your lungs? Yeah, so let's think even more basic. Start up at the mouth. Obstruction, right? Your neck is really wide and your larynx kind of collapses, right? You have cancer, right? Can't breathe through masses. You have constriction, you know, for some reason or another, subglottic stenosis, right? You've been intubated for 3 months and now your trachea looks like this as opposed to this. In the lungs, we talked about COPD, emphysema. What else in the lungs could we see? Atelectasis, right? That's really common. What else? Now let's talk about the alveoli. Mucus. What else? Yeah, the membrane, the thing that you transport the gases is not there in emphysema, or there's a problem, right? There's a problem with that that bridge, okay, into the blood. Okay, all right, and then what about in the you can see right here the vessels. Let's see if the vessels, right, that go pass by the alveoli to get the oxygen and give back the carbon dioxide. What could go wrong there? Yes. You know, the vessels are too constricted to actually get some blood. What else? Yes, PE, right? You know, you got a blockage there. You're not getting blood by the alveoli. Okay. Okay. And then at the heart level, what could go wrong? Or what kind of comorbidities might you be concerned about? Yes, heart failure, excellent. Yeah, okay, good, excellent. So this gives you a framework to kind of consider somebody's medical history, okay? They smoked for 30 years. They must have, even though they don't have a diagnosis, they must have COPD. And maybe they have, you know, bronchitis. Maybe they have an exacerbation today. Maybe, you know, the emphysema is so bad that, you know, their lung looks like a balloon instead of a sponge, right? Because in emphysema, the alveoli basically just disintegrate, okay? It's like having a bag of balloons, right? And then some of the balloons pop and you're left with just a couple of balloons and space. So you're not exchanging, right? This membrane basically is not there anymore, okay? So, or like I said, they're having inflammation, they got mucus, all those sorts of things. Okay, so this is a very busy slide, but I got it off the internet, and what it helps us to understand is the groups of things that cause hypoxia. And we're gonna go through all of these little boxes on the bottom, okay, plus this red box. Okay, first of all, hyperacute. What does hyperacute mean? And it's up there. It's happening right now, okay? Right now, this is an emergency, okay? So, aspiration. What could they aspirate? Gastric contents, exactly. You know, their secretions that they're making in their mouth. They're not ready yet to have food. They're aspirating the orange juice that you gave them. Yeah, no, yes. So mucus plugging, you said that before, right? That happens at the level of the alveoli. Bronchospasm happens at the level of the, you know, I thought that too until I was set straight 3 days ago. I'm like, isn't bronchospasm, you know, the bronchus and that, you know, kind of, no, it's not. It's the bronchioles, which is past the bronchus and before the alveoli, okay? All of that constricts and it's not getting any air in, okay? Pulmonary embolism, right? We talked about that. Pneumothorax, what's a pneumothorax? Yes, collapse of a lung. How's that different from hemothorax? Yes, blood pooling in the lung or outside the lung. Alveolar hemorrhage. So what's happening? Yeah, or they're filling with blood, right? And then anaphylaxis. What's anaphylaxis? Allergic reaction. What happens? Tell me like what happens in anaphylaxis. Yeah, right. So you're not pumping blood because all the blood, all your vessels are like, yeah, no, I'm not working anymore. I'm just gonna open up and lay here. And what else that causes hypoxia? An obvious thing. Yeah, your throat closes up, right? Can't get the air through. Again, if you think about the anatomy, these things become easy to understand. Okay, so let's talk about hypoventilation. And this is, I think, one of the most common things that you see, at least from what I've seen in the last 2 weeks that I've been here. Okay, and this little like cartoon up here kind of is the representation of like one of the bronchioles going into the alveoli, and then this little upside down U is a vessel that passes by that alveoli to try to exchange. Okay. Hypoventilation. What does that mean? They're not taking enough breaths. Okay. What is that? Yes, and they're not, they could be taking enough breaths, but they may not be what? Getting enough air. Okay. So yeah, okay. And so why, what kind of sedatives, what medications in the sedative group might cause this? Narcotics is not a sedative, although it has sedative properties. So I'm thinking more like a benzodiazepine. A benzodiazepine. Antiemetics also can cause, but I'm really thinking about benzodiazepines, like Versed, Medaz, same thing. Okay. What is sleep apnea? Yes, you stop breathing when you're sleeping. And so if you're sleepy after surgery, you may stop breathing. Okay. What's OHS? Anybody know? This is a hard one. I actually had to look this up. I'll give you a hint. It's O stands for obesity. So it stands for obesity hypoventilation syndrome. And this is a very odd thing because if a patient is obese and over time, they just don't breathe as well. It's not an acute thing. Like sleep apnea is kind of acute, right? Right now they're not breathing, but over time, if you have, like if you are obese, your body compensates by getting used to less oxygen, okay? And so your brain doesn't work as well to say, hey, I don't have enough oxygen. Neuromuscular, what kind of neuromuscular pathologies might somebody have to cause hypoxia? Yes, what did you say? I'm thinking more MD, like muscular dystrophy. What else? ALS, exactly. Yeah, yes. You know, any pathology that causes inflammation, such that like you're now having you know, an episode like MS, right? MS could also cause it. But yes, somebody with muscular dystrophy, it's very, very possible that they could have this issue. Okay, does anybody know what myxedema coma is? Yes, it's hypothyroidism that now is causing you to go into a coma. I've never seen it, but something to be aware of if a person is hypothyroid. Metabolic alkalosis, what is that?
blood is low.
Yeah, what would your pH be if your blood is alkalotic? Is it gonna be high or low? It's gonna be high, okay? So alkalosis means what? Extra credit if you know what this means. And I'll give you a hint. Too basic. What does too basic mean? You have too what? Too much what? You have too much OH. Okay, so we have OH ions and we have H ions. So H is like the acid and the OH is the base. They must kind of balance in our blood. If we have too much of one or the other, we become either alkalotic, which means our pH goes up, or acidotic, right? Because we have too much hydrogen ions. Okay. Okay. Why might I become, again, this is hard, so extra credit if you know. Why might I become hypoxic? Because I have metabolic alkalosis. Again, I have too much OH ion and I'm not balancing. Yeah. Yes, exactly. So your body might try to compensate by breathing more, okay? Because I'm not sorry, by breathing less, right? Because you're trying when you breathe less, you hold on to carbon dioxide. Carbon dioxide will eventually turn into hydrogen ions. You need to get more hydrogen ions. You need more acid in your body. So you're going to breathe less. Breathing less will cause the hypoxia. Does that make sense? Okay, that's a hard one. So. Okay, shunt. This is another group. Okay, so you can see in the little cartoon there, again, those black circles are the alveoli, and then the thing underneath there are the vessels. Okay, and you see another little thing under the major vessel that is an extra little vessel that's going by the alveoli. What is happening here?
The shunting process?
Yeah.
As far as like not getting fully oxygenated or.
Yeah, the blood is not, I mean, it's the alveoli are not working. Okay, they're not working. If they're not working, they're not exchanging carbon dioxide for oxygen. Okay, so basically your body says, okay, I'm not getting what I need here. I'm going to try to go somewhere else. All right, and so, but some of the blood that's not like that's passing by those alveoli are not getting oxygen, but it still gets into your system, right? So now you have blood that some of the blood has oxygen, some of the blood does not have oxygen. Okay, so this could happen in ARDS. What is ARDS? Say it again. Somebody say it again.
Respiratory distress.
Yeah, but what is actually happening in ARDS? The cartoon gives you a hint. You are shunting, but basically your alveoli are either too inflamed or too filled up with something that they're not exchanging, okay? And so the blood passing by there does not get oxygen. Your lungs try to compensate by moving it to other vessels, okay? Diffuse alveolar process, my assumption is that, I'm not really quite sure what that means, but seems like a lot of your alveoli are not working, okay? All right, let's talk about anatomic reasons. Intracardiac.
EFO or something.
Yeah, yes. Thank you for explaining that to me. So PF, so holes in your heart, right? Or air in your heart. So the holes in your heart can be where? Yeah, in the septum. So you can have an ASD, right? Atrial septal deviation, or you can have a VSD in the ventricle area. You could have a hole. And what happens with those holes? Why do we care? What's happening?
The area of high pressure, going to the area of low pressure, and become oxygenated, deoxygenated blood.
Right, you're not getting, all of your blood is not oxygenated for some reason, right? You could have yes. Basically you're getting mixed blood. Okay. Next group, focal alveoli. All right, what is happening? So the alveoli are inflamed, filled with fluid, or collapsed. They're not able to exchange O2 and CO2. Okay. What happens in pneumonia? Why can I not exchange? Yes, mucus and inflammation. Mucus plugging, we talked about it already. You know, something's plugging up the alveoli, they cannot exchange. Atelectasis, what is atelectasis? Collapsing, right? You know, if I have a balloon and the balloon works and then I don't have a balloon, it's not working. Okay. What is pulmonary edema? Yeah, swelling of the lung tissue. So now the tissue around my alveoli swollen, causes my alveoli to be smaller. I'm not exchanging as well. Okay, we talked about alveolar hemorrhage, blood in the alveoli. Okay, impaired diffusion. So now the problem is not with the alveoli. The alveoli can get air, and not with the vessel under the alveoli. It is the exchange. Okay, the bridge between the alveoli and the vessels. Okay, what is ILD? Interstitial lung disease. So it's kind of like a fibrosis. Okay, so the membrane kind of like shrivels up and it can't work. Pulmonary hypertension. So pulmonary hypertension can happen in various ways, but it can happen in like right heart disease where the blood is backing up, right? And if the blood backs up, I'm not really quite sure I understand how it affects that bridge. So I might have to look into that, okay? And then advanced COPD. What's happening at the bridge? Yes, they do retain too much, but the bridge is broken how? How is the bridge broken by COPD? Or more specifically, emphysema? And I talked about it before. Yeah, or disintegrating. Disintegrating. People who smoke a long time, their alveoli, basically the balloons in the bag, they had 10 when they started, smoking, and now they have 2. Okay, so the exchange space is really low. Okay, that's why people with COPD, we have to let, we tolerate 88 to 92 because they cannot produce more. They cannot exchange because their balloons or their alveoli have disintegrated. Okay, dead space. If anybody won't know what dead space is, and feel free to look at the slide. What's dead space?
The area between your lungs and I guess your mouth.
Try again.
The vessel where they exchange, where it's just like what? For pulmonary embolism.
Yeah, you're getting air into alveoli, but there really is no vessels, there are no vessels to bring blood by. Okay, I think you have a lot of dead space. In normal people, we have dead space up here that we don't have as much exchange as in the bottom of our lungs. Okay, when we put somebody on a ventilator, we get a lot of dead space, right? Because the circuitry is not exchanging. So it's basically spaces in your lungs or outside of your lungs that you are connected to that don't exchange. Okay, how does a pulmonary embolism cause dead space? Blocks the vessel, right? I can't exchange if I don't have blood going through. If I have a blockage, I can't exchange. Okay, we talked about emphysema, but one more time, what is emphysema? Yes, it's disintegrating alveoli. Okay, so you really don't have, you don't have alveoli, so I'm not sure that I understand this picture with it. Okay, positive pressure ventilation. I'm gonna have to get back to you on that. And then we talked about a little bit about pulmonary hypertension. Basically, your vessels are not open enough to be able to pass blood. And then shock. What happens in shock? And anaphylaxis is a type of shock. What's happening? Dilation, your blood's not moving. Your blood's not moving, right? And you can have different kinds of shock, cardiogenic shock, your heart's not pumping, okay? Anaphylactic shock, your blood's not moving because your vessels are dilated. So you can have septic shock. Not sure why the blood doesn't move in septic shock. I'd have to look that up. Or maybe other processes are, your blood maybe is not getting to the organs, or if it's getting to the organs, it's not really perfused. So in any case, your blood is not moving for whatever reason, okay? All right, airway disease. We talk about this ad nauseum. Asthma can cause, why am I not getting air exchanging in asthma? Yeah, you're restricted, right? The asthmatic patient, they might have constriction. They might not be able to get enough air through, even though their alveoli might be working, they're not getting the air there. COPD, we talked about that a lot already, okay? And bronchiectasis, so that's kind of a collapse of your bronchi, okay? All right. So, going back to this chart here, we've gone through all of the reasons why you might have hypoxemia, okay, or hypoxia. Okay, and then I just want to show you, I really wasn't going to delve into this too much, but do you see that some of these, some of the groups are responsive to O2 and some of them are not, okay? So if you give oxygen to a person who has very little alveoli, that might help a teeny bit, but it's not really you need exchange space. If you don't have it, it's not gonna work. If you have somebody who has the alveoli are filled with something, mucus, fluid, blood, doesn't matter how much oxygen you give them, right? They're not gonna exchange, okay? But if you give somebody who has sleep apnea oxygen, right, they might not be breathing enough times, but when they do breathe, they're taking in more oxygen. So in sleep apnea, it would help. Does that make sense? Okay, all righty. Okay, so interventions. So you are looking at your patient, right? And you see skin color is blue or red, okay? Ask yourself, how are they breathing? Is it noisy? Do I hear stridor? Are they using accessory muscles? What does using accessory muscles look like? What is it? Breathing from the belly. Where else can you see use of accessory muscles?
Lungs, upper,
Yes,
shoulders.
up here, specifically if they're a thin person, you'll see this, okay? And then you maybe look in their gown. Are they, particularly in babies, you'll see retraction, okay? Good. Okay, talk to the patient, okay? Are they alert? Are they oriented? Remember, the person who doesn't have oxygen going to their brain is kind of like the person that goes up in a plane without oxygen, okay? And that's why when you go up in a plane, the cabin is pressurized to have oxygen, because if it weren't, you would also be loopy, okay? Look at the vitals. The OSATs, are they normal, right? Are they normal for that person? Maybe a COPDer might need to have more permissive low sats. The heart rate low, why is the heart rate low? Somebody tell me. Not enough oxygen to the heart, okay? All right, so consider their medical history. Do they have lung disease? Do they have heart disease? Are they a smoker? Do they have a history of OSA? Do they have OSA even though it's not diagnosed? Do they have OSH, the obesity, OHS, obesity hypoventilation syndrome? What about their surgery? Was it painful? Did they have a lot of bleeding? Okay. Do they have a lot of atelectasis now that they've come out of surgery? Consider what medications we gave in the OR. Did they get Midaz up front? Did they get a lot of opioids? Did they get, oh, I'm sorry. So, yeah, so sedative medications can be things like dexmedetomidine, right? And benzodiazepines like Midaz or Versed. Okay, so what can you do? What can you do?
Stimulate.
You can stimulate them, yeah,
Vasopressor, more oxygen.
more oxygen. You can also, what? Your name? Yeah, you can put it at the head of the bed up. This is, you know, what I have noticed, and when it's being here for 2 weeks, is that, you know, I'll suggest put the head of the bed up, and many of you are like, okay, I'll go 5 degrees. Put the head of the bed up, okay? I mean, bring it to 90. You know, if they can tolerate and it's not contraindicated, put the head of the bed up. That might be your best intervention, okay?
Depends on size of the patient. Sometimes if you jam their blood so far, you know, you kind of talking outside of surgery and some of the surgery stuff. I know what you're saying.
Maybe so, but if you think that putting the head of the bed up, it might be an intervention to try, really try it. That's what I'm saying, okay? Don't be afraid, again, if it's not contraindicated, really try to put the head of the bed up. You can also like turn their head to see if you can get like a more straight airway, you know, more open airway. Sometimes that helps, sometimes it doesn't, okay? They might need an oral airway, okay? Ask for help. Should we put in an oral way? They might come out with an oral airway. Be very careful before you remove that, right? Because maybe that's the only thing that's keeping their upper airway open. Tip the foot of the bed down. That will also, particularly in an obese patient, you want to get that tissue off the lungs, right? Off the chest. And if you chip the whole bed, okay, not just bring them up, but tip the whole bed, reverse Trendelenburg, you may be able to get some help there, okay? And then of course, put on the O2. If you crank it up, that's not working, we have to go to the next step. Maybe you need a rebreather, maybe you need, positive pressure, okay? And then of course, ask for help. Okay, sample case. And here's where I want you to, after we do this, I want you to think of your own stories, okay? Because when you hear other people's stories, that's how you remember, okay? So we have an 80-year-old male patient with a BMI of 45. He's a 30-pack year smoker, and he's undergoing an open laparotomy. What are the risk factors here? Yes, smoker. Anesthesia, the surgery. He's 80. Okay. All right. In the PACI, you notice an O2 stat of 91. What do you think could be causing this? He might just be. What else could it be? Hypoventilation, right? He's just not because he's obese or because he has undiagnosed OSA. What can you do to help? Lift up the head of the bed. Yes, what else? Put some oxygen on him. Good. I have noticed also that, I don't know, maybe it's a cultural thing, but I've noticed that people are reluctant here to put the oxygen on. Is that true? No? Okay. You think it's true?
No.
No, okay. Okay, and I don't know if it's, I kind of noticed a little bit of that, but maybe not. Maybe I'm just. Yes, and that was what I was thinking, is that they're reluctant to put it on because maybe they won't be able to get it back off. Okay, so if they need it, they need it, right? You don't want this person not to get oxygen to their brain. Okay, what else can you do? Yes, Right? Yes, yes. And then lastly, if you don't know what else to do, you get help. Okay, all right, so that's kind of the end of my presentation. So I want to hear, like, tell me some of your war stories.
So I'm an intern. I started 3 days ago, but I came from 6 internal medicine. And there's this patient like a long time ago who told us he was going to code.
He
And
told you he was going to code.
he told us he was going to code.
Okay,
And we were giving him his home dose of Dilaudid.
okay,
And so he told the day shift nurse that and myself. And so he told the people above us we couldn't really do anything about it because he was stable. And at shift change, we did like a handoff. And then when I brought his meds, I asked him if I could go get him water. So I got him water. When I came back, he was like dead. So he was blue. You know, whatever we coded him, he was in the ICU for a couple of days. And then when we came back, he had PE, a collapsed lung, an infectious process on top of his obesity and his like lung history.
and opioid use.
Yes.
Okay, so you saw everything in one patient. Yes. I don't know if the people in the on Zoom could hear that, but basically, Taylor? Yeah, Taylor had a patient on the one on the floor that had Dilaudid in his formulary, and he was obese, and he told us that he told her that he was going to code, and he actually did. And so he had lots of risk factors. He also had an infectious process going on. Any other? And then we'll end. One more war story.
I don't have a war story, but I do have a patient that always sticks out in my mind that it was the, here in PACU, we're always juggling dealing with, is it a respiratory issue or is it a pain? Like, what are we treating? But it was a patient that had an abdominal surgery. I remember exactly what it was, but also had an epidural. Kept complaining of pain. The epidural wasn't quite working, but her stat kept going down. And so, long story short, what I had to figure out was that she was destatting because she wasn't taking a deep breath. Basically, that's like the moral of the story, was that I had to treat her pain to get her to be able to oxygenate appropriately. So then I could give her or evaluate to see if we stick with the epidural or another adjunct for pain. So I think in PACU, like, we're constantly thinking about, like, is it something that we did, we caused the hypoxia, or something underlying, and then how do we treat both, like the hypoxia and the pain at the same time safely? But once her pain was under control, she then was able to take a deep breath, oxygenating. And
Yeah.
and that's just like a simple. Like,
Yeah, no, I think it's simple, but it happens a lot.
Yeah.
And it's something to keep in mind. If you treat, you have to balance, right? Because if you give too many opioids, they're going to stop breathing. But if you don't give enough opioids, they're not going to breathe deeply enough. Okay, any questions? Yeah.
Go home like she's in her 80s, and her acne just kept out that she got that he got that. He had recently had like a leg injury, and I forgot he had some type of ortho surgery, but I think it was like on her arm. So they don't anti-coag apparently for certain areas. So like he couldn't very well do chest X-ray. He ended up having a
Yeah.
I know.
Yeah. Yeah. So, and supraclavicular blocks, I'm just trying to repeat for them. Yes, so supraclavicular block, which happens kind of in the shoulder area, can affect the phrenic nerve. The phrenic nerve affects your diaphragm. The diaphragm causes you to breathe, right? So if you get that blocked, you may not breathe as well. That's a fabulous example because it's really not their history, right? It wasn't really the surgery. It was something that we wanted to give them for pain. So I think that's an excellent, I'm glad you brought that up. Okay, well, anyway, thank you for your time. I appreciate it. Feel free to come by and ask questions, but it's really been wonderful working with all of you these last 2 weeks.
Thank you. Well done.
Thank you.
Cool. I think I got everybody attendance wise. Thanks,
Alrighty.
everybody, for zooming in.